All right, I'm Pat Kelly. I'm from Charleston, South Carolina, and this is one of the things that's near and dear to my heart. If I had to identify one of the things that was contributing to me leaving emergency medicine early was our electronic medical record, and now we have improved it, and I just wanted to share that process with you all. Our group overview, just so you know, have an idea of us, there are 3 facilities with 5 emergency departments. 2 of these are freestanding. One of the freestanding is in a more rural setting, and the urban hospitals and the freestanding ED are more localized in the city. Total visits for 2012, we have 126,000, 15,000 admissions, and 45% of all of our patients that are admitted to the hospital come through the ED. Now, embedded in some of that, for example, one of the freestanding EDs has 20,000, and they only admit maybe 7 or 8%. One of the main hospitals, Roper Hospital, has 32,000, and there are days when we admit 30% of the people we see. So we have a high volume and high acuity there. Our problem statement, after using McKesson, which was our electronic medical record for 7 years, and we had multiple levels of frustration, broken promises, we said enough is enough. And so I described to you the process that we used to make this change, and we taught our healthcare system a few lessons. In 2006, our system started as a beta site for McKesson, and being a beta site was all important, and we thought that was wonderful, and initially they promised us the world, and then it slowly started to disintegrate. And by the end of the process of using McKesson, they would say, all right, we're having another upgrade in 2 days that should fix this, this, and this. We called them downgrades, and we referred to them, administration, as downgrades. They would take processes that were in the McKesson EMR that worked and would break them, such as discharge diagnosis, some of the discharge medications, things that were not wrong. They had frequent downtimes, and they were awful. And scheduled downtimes would turn in from 3 hours to 24 hours to 36 hours. And so it just really was complicated. And the process was slow. And it didn't keep up with all of our measures that we're having to use based on stroke, TPA times. We had to add Wells criteria. We had to add additional stuff for pneumonia and sepsis. It just wasn't there. And we used Dragon. And so, you know, the first using the Dragon, you had doctors that weren't reading some of the statements that they would put. One of the charts came out, and what was supposed to be was a retired minister under a social bullet, and it came out child molester. So I mean, we had lots of problems with it. It would also come up with things like it would ask you, is this person elderly? Are they at risk for falls? Are they an alcoholic? And you'd say yes, because it was a little granny who had fallen 3 times. She'd get an automatic ICD-9 code for chronic alcoholism. And we didn't know those kind of things were going on with it. And so we said, okay, what are we going to do? And so administration said, okay, put your money where your mouth is. Go look and see what you can come up with. And so this is the process. We went and evaluated for the best of breed. We secured the capital, and then we selected, purchased, and implemented. The process that we use is PDCA, this plan, do, check, and act. It's not just a one-time thing. It's a repetitive process. So we're cutting back now in after we have implemented it to say, okay, what's working and what's not? What are we going to change with it? Early on in 2010, we looked at CLASS. CLASS is information services that evaluates information technology used in healthcare. And so we said, all right, what are the best 5 programs that you have that can do an independent, not bundled in together, such as Cerna, but independent we can use, and we came up with WellSoft, PISIS, MedHost, Allscripts, and the T-System. And we sent a delegation to Miami to look at that. We named a selection committee in 2011 and then went through a pretty rigorous process to decide which ones were good and which ones weren't. And so part of the due process in this, we had an ED clinical nurse specialist. She was dedicated to this strictly. She's a nurse practitioner, seasoned ED nurse, knew what we needed and wanted, and she also just happens to be very savvy on information technology. And so she coordinated this. We had an IT person that was assigned to our team as well. And we used the clinical selection people. We used frontline nurses and doctors from multiple places. Just to give you an idea of the different participation, the search committee that initially went down to Miami and looked at the processes, these were some of the leaders within our group and some of the clinical nurse managers from the different EDs. Then we changed it to add additional doctors and nurses from each of the facilities. So the selection process, what we did is we rented a hotel ballroom, and we had the 3 vendors that we chose as the best that could satisfy our needs. They came in, and they were at each station all together, and people could come in and go from station to station to station. And so we could see in real time, this is what this one presents, this is what this one presents. And then they sat down with formal group discussions. They had a checklist that they used. These are the things that we have to have on our new electronic medical record. And then they scored them, and whoever scored the highest on that ended up with the 2 that we came up with. And so after the first section, we eliminated Wellsoft, and we were down to Pisces and MedHost. And then the selection team continued on that, and finally we ended up choosing MedHost. Then we began the contract negotiation, and it used people from IT, and initially the information technology saw us as a thorn in their side. We were kind of bucking the system. And by the end of the process, they realized we knew what we were talking about. Plus, they were in the process of implementing computer order entry for the physicians, who were a conservative bunch that were not real computer savvy in some of the places. And so they knew they needed our help. And those are some of the lessons we taught them. We signed our contract in December of 2011, and then we began building the system. And you can see who all was involved. We had RNs, we had radiology, we had pharmacy, we had IT. We brought them all together, we paid them for their time, and we came up with a good product. We implemented just in November of 2012, and so we started at our new hospital, Mount Pleasant, because it has a mixed acuity. We take care of a lot of elderly patients, but we also do some clinic, and there are days you may see 50 patients and admit 4 or 5 of them, and then there are other days you may see 25. So we saw that as a kind of a mixed bag and would allow us to see what's going on first in a small facility. After we succeeded with that, then we went to St. Francis Hospital, which has the largest volume of patients, although not the acuity that Roper sees. They admit maybe 15% of their people. And just to give you an example, this ED group, who is separate from mine, had gone back to a paper T-sheet because they were so frustrated by the McKesson product. And then we implemented it systematically at the other places. The 2 freestanding places, Northwoods and Berkeley, that's interesting because Northwoods, we were doing computer order entry on the computer, but all of our paper, both nursing and doctor documentation, was done on a T-sheet. And this Northwoods was one of our first freestanding. And in order to go there, you had to be a seasoned ED provider and be experienced and trusted and good clinical judgment. And so we had nurses in the 60 and 65 range here who were not real computer savvy, and we had to bring them on board, and they're doing fine with it. After we implemented, we looked at the throughput metrics, and MedHost had said it may take you 6 months to get back to your productivity levels. And within 6 weeks, we have returned to what our baseline was. And all EDs experienced a 15-minute improvement in the discharge length of stay. We're now looking at our admitted lengths of stay. And we've learned in this process, when you control housekeeping that's doing the beds for admission, when you have the admission nurse that's under your charge, you have a lot, and the bed controllers are all under your charge, then you have control over the process. So these are the lessons we learned. It took us over 2 years, 2 years and 3 months from the time that we said, let's go look at something different to the time to implement it. And we had become victims of it. I mean, it was just, okay, another downgrade is coming. What else can they do? I hate McKesson. And we took charge of it, and now we've learned that nobody cares about your electronic medical record more than you do. So, as I said, under barriers, initially the IT department saw us as obstinate, but then by the end of the process, we were able to help them. And we also helped MedHost, because MedHost, we took them to places that they had never been. We were the largest enterprise system they had to deal with, and we had 21 interfaces that they were charged with fixing through McKesson because they weren't going away. It took us $2.5 million in order to implement the MedHost, and it was $1 million in cost of human resources, but it has paid us dividends. And just to give you some of the outcomes that we're already receiving, the reports that we generate now are so far superior to what was coming from McKesson. And so now we're able to make a difference in it. You can see here, these are our go live discharges under 180 minutes. Some of the lower acuity places, 86% there. Some of the lower volumes and less acuity, we were doing okay, but still not doing so good along this range. And now, just in the several months since we've implemented, you can see our curve. We're all up here. And our goal is 90%. That's what administration pays us an incentive bonus to achieve, 90% of your discharged patients within 180 minutes. And so that's what we're trying to achieve, and the patients like it also. As far as other outcomes that we're looking at, the pre-go live, you can see some of the places we're having a tough time getting door to doctor. And this is absolutely reflective on patient satisfaction. If you're waiting an hour in the bed for the doctor to come, they're not very happy. And you can see that the lower volume places, it was easier to get in there to see them sooner. Length of stay overall, you see it there. Below, well above 180 minutes on some of them. Look at the door to admission, 428 minutes. So that's a lifetime while those patients are waiting in the bed, not to mention your incoming volume that you can't have a control over. And then your length of stay on discharged patients, 180 down to 102. And so after our go live, you can see door to doc, almost everybody is achieving under that 15-minute goal that we're doing. Some of the places, Berkeley, that is still new to this, and St. Francis, who had the biggest gains to make, are still not quite there yet, but already we've made a significant dent in it. And you can see that our length of stay on everybody has gone down. Now we're below the 180 minutes there. Length of stay on discharged patients, we're doing very well. So that's our system, and I think we're making headway. And the other lesson that we've taught our hospital administration is that now they are looking at abandoning McKesson for their system. And they're going to have, and they're contemplating going to Cerner, and I would appreciate any input on you guys who are currently working with Cerner. But we have said that we are willing to go to an even different EMR if we have to. But this McKesson system as a whole was just absolutely, like I said, it was awful. And so I'm glad that we're here where we are right now, and it shows me that maybe I don't have to leave anytime soon.